right, we're recording. We're live on this one. All right, let me turn this
Episode 2.
guy off. All
That's
right.
going to be our intro. Me singing the episode number.
Yeah.
This episode is titled Meet Cute.
Meet cute.
Oh, I like
Meet
it.
cute. So test. Oh, nice. We get to see your recording there. This is our test episode 2. Today we're joined by you. If you're tuning in, it's 3 doctors just shooting the breeze. But for everybody's sort of comfort, this is Adam. I'm Vahid, and this is Pegah. Adam is a doctor in physical therapy. Am I saying that correctly? Is there a different way to say that? Okay.
I believe it's pronounced docteur
Doctor.
of physical therapy. Yeah, but we'll work on that. I forgot we're passing back and forth. Yes.
Yeah, this is kind of weird, and I'm kind of thrusting something towards your face, which is not comfortable.
Would you like to give us some notes on this as a psychologist?
I wait until the end.
Okay.
To
You
make
have your
my
own mic, so we-
interpretation.
That's
I
quality.
want to make sure I get
I appreciate
the
the
full fee
professionalism.
before
Yes.
And I feel so much happier that you and I chose to do this,
Yeah.
because this is, we're keeping you safe from
you.
this situation here. Do you want to just real quick, just kind of give a rundown of what you do, sort of what's your area of
Definitely.
expertise?
Yeah. Oh, I need the mic. Yeah, physical therapy, doctor of physical therapy. The way I explain it to patients is I am using you. You are the tool, right? We are trying to get some sort of change using your own tissues, right? So whatever that tissue is, whatever change we're trying to get, we need to apply some sort of stimulus to get some sort of tissue adaptation to occur in order to reach our goals. Right? Whether that, so if that stimulus is exercise or stretching or soft tissue work, doesn't really matter as long as we know the tissue, what tissue we're dealing with or tissues, as long as we know the goals we're trying to achieve, and as long as we understand how those tissues respond to different stimuli physiologically, we can be very, very, have really, really good outcomes in terms of providing the correct stimulus. But you just got to know those 3 things. So that's how I like to think of physical therapy.
Nice.
Back to you.
Thank you, Adam. Pegah, same question for you. Just tell me a little about what you do. What's your sort of area of interest and focus?
Okay. So I'm a psychotherapist. I feel like that was a really good rundown of, I feel like what I do is work with the person. And then we sort of figure out what the goals are and how to proceed from there. But in particular, my specialty area is in EMDR, or I would say now more broadly trauma work. So how you would want to consider trauma as a specific area of specialty in psychotherapy is that an event or events can happen that are considered shocking or overwhelming to the system. So they create some kind of an injury, speaking to the physical folks in the room, the trauma gets held in the body in a very specific way, kind of gets frozen in the body with the original content or the image, the sound, the experience is held in the body in that specific way, and then it does not get processed through into long-term memory the way that any other normal memory would. And that's when I come in, because a client will come in and have symptoms as a result of that. Thinking about nightmares and hypervigilance and flashbacks and things that create symptoms in their lives. And then I help them work the memory through so that it gets processed. It gets, quote, like to use the word digested, so that then it can get filed away into long-term memory, like other emotions and other memories would. And usually we say, that doesn't mean that the event stops being bad. It'll never stop being bad. That's not the point. But it won't be stuck in your body the same way.
I agree with that. That makes a lot of sense, the way that you just put it. So it's like this experience is kind of banging around in the wrong place and not allowing to be sort of like flowing and processing and you moving on from it then.
Yeah, exactly.
I'm already sort of and maybe that's the note that you're taking, but I'm already sort of like seeing how this might
So
tie
much.
in with physical.
I've got questions.
Yeah. Well,
Yes.
well, okay, go.
Questions. So I love that. That's super interesting. Is there a difference between psychologist and psychotherapist? Or is that kind of interchangeable?
It's in the field, it gets very specific. As a psychologist, I've gone through a specific degree program, so I have a doctoral level degree. I specialized in my field in clinical psychology, so people can become experimental psychologists, they can become sort of more research psychologists. In my case, I wanted to be more applied. So clinical meaning folks who come in who have certain ailments or disorder, diseases, however you want to think about it. So that's where what I went to school for. But I am, on a day-to-day basis, I'm a psychotherapist, meaning I sit in the room with my clients and we do psychotherapy. A lot of psychologists who are clinical can become testing clinical psychologists. So a lot of their time is spent testing to figure out diagnosis, like is there depression, is there anxiety, is there trauma, are we looking at access to disorders, personality disorders, things like that. Neuropsychologists are also clinical, so they might be doing testing as well. They're looking at ADHD testing or IQ testing or other forms of neurological.
So you're very like patient interfacing with
Yes.
with the psychotherapy part.
Yeah.
That's super cool. Is it so you were speaking to describing sensations that are not going or finding the correct pathway for long-term storage?
Yeah.
Is it purely sense-based? Smell, touch, visual? I mean, everything is, right?
Sure.
But would you see, like when I'm dealing with something, it's, muscle, tendon, ligament, bone, fascia, nerve, whatever. I have these specific tissues. Do you have to change how you practice based on the type of sensory overload it is? Like, is it auditory? Is it visual? Is it sensory?
That's a really good question. No, you don't. You just have to know to ask for it. So if a client is coming in and saying, I had a car accident, and so I'm noticing flashbacks, the images keep coming up in my mind, or when I hear a sound, I jump, I have hypervigilance. When I ask the question of how do you remember the experience, and then there is the additional issue of people can black out during a car accident. So they don't remember the moment of impact. They might remember several moments later, and they have a bit of amnesia. Anyway, that's a longer conversation, but I'll say, how do you remember it? And they'll say, well, I don't really have much of an image, but man, can I hear the screeching of the car? Or I see the red tail light and I'm shocked. Or in my case, I remember coming to after I was blacked out for a minute and I saw the airbag. And that was the moment of impact that I've held in my memory bank. So, and when we think about EMDR, you want to think about it as like there's a starting point. It's like kind of starting on a train. You start on a train at a train station, but that's just the beginning of your journey. And then once you're on the train, the EMDR train, as my colleague and I like to call it, then whatever part of the memory comes up is part of the work. So that kind of can get a little confusing, but that's just kind of the starting point.
No, that makes sense. That's a really succinct way to explain it, I think. I guess the next question, and then I'll allow you some questions as well, Doctor. I'm really curious to get a better understanding of, does it matter the patients exploring these memories? It's probably very unreliable in some way, whether it's overstimulus or just the nature of our memories.
Sure.
As far as I know, are not the most reliable. And when I'm interviewing a client or going through a history, I really try to tease out like the most objective data points, like what actually happened, what are you actually feeling. But yours doesn't. Maybe it doesn't matter. Correct me if I'm wrong. Does it not matter if it's a reliable, accurate memory, or if it's just completely made up because it's what they experienced? Does my question even make sense?
It's a little complicated because that I would say is somewhat controversial in the field. I will say for myself in real time, if I'm sitting with a client and I say, what's coming up for you now, is usually what I say. I'm looking at certain 3 things. I'm looking at, well, is there a memory that just came up? And they might say, yeah, as I'm thinking about this memory of the car accident, now I'm back to being 6 years old on the playground when I fell off the monkey bar, right? I'm not questioning it. I'm just saying, let it come up. I'm also asking very regularly, and how do you feel now as you recall that memory? That's pretty much what you will see me do as a therapist in the room. How do you feel now as you recall that memory? And one of the most important things about that is that we talk about the past is present with trauma, meaning, yes, it's a past memory, but the impact is present. Mm-hmm. So the impact is right now. Mm-hmm. How do you feel now? What are the sensations in your body now? So yeah, the memory could be, conflated or, could be off a little bit. That's not so much the issue. What the issue is that whatever that memory was has an impact now.
Gotcha.
So we really, once we're on our train and we're off, we don't really kind of question it, especially because that a big part of what happens with folks who have trauma is that they develop a lot of shame, and that there's a very good reason for that. And so you don't want to question how the memory is coming up and just let it work its way through. The whole point of, and this may be very similar to what you do, but that the body in and of itself has an internal healing mechanism, right? And what we have to do as clinicians is figure out how to set up the scene, set the scene up so that the person can move toward adaptive, move
really like
toward
that.
Health. Yeah.
I love that. I would say I'd bring it over to you. How do you feel like you set the scene to help your patients?
Okay, thanks. I'm kind of liking where this conversation was going. If you're comfortable with like expanding a bit, as the least smart person in the room,
For sure.
I'm gonna dial
Of
it
course.
back and
We
a little
agree.
simpler. I just for those that may not know, what is EMDR in a basic sense? What does EMDR even stand for? Let's start there.
Sure. So EMDR is eye movement desensitization and reprocessing. It was developed by, the great Francine Shapiro, who is now no longer with us. The interesting thing is that the story goes that she sort of accidentally stumbled upon this, but I'm sure it was sort of a lot of educated guesses that got her here. And then from there, the original model has now morphed and become an entire library of treatment protocols is what we call it. But the gold standard protocol is essentially, like I said, so if we think about that a memory gets held in the body, and I do this because it's a moment of shock, right? Even if you don't remember the moment of shock, that complicates things. Especially if we're talking about a child who's preverbal, that complicates things because we only have our memories because we have words. Our memories are encoded in a certain way because of our words. So if we don't have words,
You're breaking my brain.
there you go, right? How does it get encoded? It might get encoded in ways where the person says, well, I don't have words for this, but I have a memory. So sometimes I'll say, okay, you don't even have to remember up here. You might remember in your body. So things can get very
Could that explain like why certain people are just uncomfortable in certain scenarios or with certain sounds, but they don't know why?
Yes.
Okay.
Yes, exactly.
Is there a what could you say to somebody who is unsure if they're dealing with that? Like, is there an easy way? I know nothing's easy in your world, but is there an easy way for them to self-identify if they are triggered or more sensitive to some sort of scenario or environment or stimulus?
Oh, that's so hard. I mean, that can get so complicated because we're not only so this is kind of heading into the direction of what I really do. I don't always work with people who've had car accidents.
You're actually a car salesman.
I am a car
Okay,
salesman.
this is what you really do.
Thank you for
Insurance,
lightening
maybe?
it. Yeah,
Okay.
because I'm about to get into what the real more complicated issue is. I didn't realize this when I first started learning the EMDR, but what I really do is mostly work with people who have complex trauma. So complex PTSD is typically people who have had traumatic incidents occur to them on a regular basis, usually starting in childhood. So you can fill in the blank of what that might be. And like I said, the shame sets in, especially for kids, because a child, when something has happened and happens and they feel really helpless, it makes sense that they associate what's going wrong in their lives with me. It's my fault. And you both know this. You both have kids. So I can imagine you can kind of start to think about it in that way. This is why, like, it's really important that a child knows that they're loved even when something's gone wrong. Or that's creepy.
That's a wind from somewhere.
Those children.
I
Yeah.
know. Thank you.
The
Pegah,
mics
thank you.
won't pick that up, but yeah, for those wondering, it sounded like a
No, there's
Yeah.
howl.
Yeah. And they're welcome.
Yeah.
Those children are definitely welcome. So anyway, long story short, this is why we look at pre-verbal memories that don't get encoded in the brain like other memories do. This is why we don't talk about necessarily always, in our field we talk about capital T trauma versus lowercase t traumas, right? Because a lot of the time person says, I have all these issues, but I don't know where they come from, or I don't know why this is. I had a great family. There wasn't really anything wrong. It takes a little while to start to understand what the issues were based on the symptoms that are being presented in the room. So present day symptom, tracing it back to the past, it takes a little while. And it's also not necessarily that the person has this, uncovers this big memory that says, oh, this is the thing that happened to me. So yeah.
Do you think there's I always, again, I'm a physical therapist, so a lot of what I see is on the spectrum from of acute to chronic, and I see a lot of summation or summative effects. Like maybe these little things here and there have caused this global catastrophe of tissue.
Yes.
Is that something you see? Like
Yeah.
it builds and adds up? And is there any quantifiable measure or way to measure that, would you say? Or I'm sure it's much more complicated than that, but it's like, I've had 3 minor traumas in my life. That puts me in the major T category. You know what
I
mean?
wish.
Yeah.
That would be really nice. We haven't quite figured that out yet. But,
Or at least patterns, if you've seen any patterns.
patterns, yes, because human beings are patterned. But I think it was something you said. Oh, I can't remember now. I lost it.
While you're thinking about that, I wanted to, what is classified as a capital T or big T? Large T?
Yeah.
What was the word?
Capital T.
Capital T?
Capital T traumas is
Capital
what we
T
say.
traumas,
versus
like what
lowercase
sort of
t
falls
trauma.
under that category, and what's the lowercase t? That was one question I had, and then I forgot the other one, so you go ahead and answer that one.
Okay, so this, again, complicated. What's interesting sitting in this seat is I feel like my entire field of educators and clinicians and researchers and clients, like I feel like I'm representing them right now, and it's a really large task.
Okay.
It kind of feels really overwhelming. I feel pretty overwhelmed because I have so much, here we go. I have so much respect.
Take your time, and we can move on to a
Yeah,
different subject. Yeah.
it's
We got
so
grab the mic.
sensitive.
No,
No.
I think this is good. if you're comfortable.
I can keep going.
I think that's an important thing to think about.
I have it in my office because I'm a therapist and I have tissues.
Yeah, why'd you go to your office to get tissues? Are you making people cry in there?
I am.
Jeez.
Just for different reasons. You know.
Thank
Okay,
you.
we need to bring the board back in here.
But yeah, I mean, when you talk about capital T trauma, you're thinking about like some of the most horrific things
Yeah.
that people don't usually want to think about or talk about, but that people live with on a daily basis. You talk about physical abuse, sexual abuse. You can talk about scarcity, people who lived a life of having no access to food, being, every single day being yelled at and dismissed as humans in one way or another by the very people who needed to protect them and keep them safe.
Yeah.
So I'm always super honored that someone would be willing to come in and share their story with me.
I love this. I hope you're not uncomfortable, but
No,
it just
this is
to
what I
me
do.
it speaks to the quality of provider you are, that it affects you this much. I mean, I love to see that. I wish there were more of you in our world, and especially in our health system. But there's so many interesting things you said in there. I mean, we could dive into any one of them. I think one of the things that I can really relate to is feeling like there's a pressure of, standing on the shoulders of the giants, the predecessors, the people in your field that have really made leaps and bounds forward and allow you to continue to progress in individual fields. And it's like, all right, how do I respect them? How do I honor them? But also, how do I continue moving forward and building on the path that they have allowed for me? I feel that all the time. Mine's like a fairly broad field, so I have a lot of, and a fairly broad field and a field that a lot of people wouldn't really know what it is. Like, what is therapy, or what all can it do? So I kind of feel that pressure a lot when people ask me, what is physical therapy? Mm-hmm. Like, I have something. What could physical therapy do? So yeah, just want to say that I can relate to that. Yours comes with the added bonus of really, well, for lack of a better word, empathizing with the patient. I imagine this is probably a discussion for another day, but the potential for burnout, I bet, is massive.
It is.
But I appreciate you being vulnerable.
Thank you.
That's good to see.
It'll happen more often than you think.
Not with us, because we're men, and we gotta be stoic, right?
I wanna echo actually Adam's words. That's exactly my thoughts in that. Being sort of generous with your expression of this here, right? Because it does take generosity in this space to sort of just openly talk. I really appreciate that, and I know Adam does, and anybody that's listening, because we don't get to see that side, right? Especially, like, the last thing a client wants to see in the room is you, like, breaking down with them, right? Because they're like, hold on, dude, I'm here, for you to help me. Like, you can't, like, break down.
Could you pass me a tissue?
But it speaks to you.
But also, I'll bill you for that.
Yeah, exactly. Yeah, tears are extra. No, but it speaks to this concept of human beings supporting and treating and helping other human beings process things, especially with trauma processing, as you described it. So yeah, I really, really appreciate that. And then if you think about it, when it comes to clients, patients, you have essentially the most vulnerable, right? And like you said, sometimes this is layers and layers deep. And so they don't even know it's about to get vulnerable, and it might hit them like a ton of bricks in the room with you in that moment. And so to have someone that they feel safe around and a space that they feel, so it's a big responsibility. And but
oh yeah, how do you prepare somebody for that? That's what I like. You were asking me earlier, like, all right, Adam, you're a physical therapist. How can you bulletproof? I'm gonna steal this from you. Yeah. How do you bulletproof your body? But I'd pose the question to you, like, how do you even prepare to do the work? Mm-hmm. Let's say a warm up for a workout. Is
Right.
there something you can do, or what would you say to people in preparation to come see or work with somebody like you?
Yeah, that's a great question. Actually, in the world of EMDR, it is very important that we prep our clients, and so we have these methods. We actually support them in developing coping strategies first, some kind of a coping strategy to sort of, as best we can, to prevent overwhelm. It's, we kind of walk this tightrope of, maybe similar to you, like we want them not to feel overwhelmed, and we also know the only way to do the trauma work is to go through the trauma. So there isn't a workaround, but how do we help them have the resources available to them to prevent them from becoming, of course, re-traumatized is one. So we have different tools and techniques that we use. One of the most important ones that I think is super essential to the foundation of what we do is called dual attention and awareness, dual attention, which is when you're recalling the memory or anything in the past, are you aware of where you are in the present moment?
Okay.
So that's what 1 foot in the past, 1 foot in the present is what we call it. So that the person doesn't get overwhelmed and get sucked up by the memory. So we're using a lot of present moment stimuli.
It's like an anchor.
Yes. So I even have essential oils in my office, and I'm like picking it up, having them smell it, because that, the olfactory sense is really grounding.
Okay.
Or having them take a look around the room and name what are the colors you see, what are the sounds you hear, touch the couch and notice what's here. We're doing that throughout the work, because the risk of them being taken up by the memory means that once they're taken up by the memory, you're not really even helping them. You're actually kind of perpetuating the injury. So that's one thing we do a lot, but then we're also training them in other ways to help soothe their nervous systems so that they don't go outside of what's called the window of tolerance.
Okay. And I mean, that's why I think doing something like this, not necessarily like, recording it, but sitting with colleagues in similar fields or even in the same field and talking about it, allowing us to sort of like vent and process our own emotions is so important, because across our fields, I think one of the common things is we are receiving people who are in a vulnerable state, some more than others, right? You have somebody potentially with an injury, right? They're feeling less than. They're feeling less confident. They feel like maybe they won't be able to play that sport again or walk the same way, or et cetera. I'm getting people come in and say, hey, I didn't know I had a high blood pressure, and now like I have this label, and there's a vulnerability to that. Right. And so when you deal with that, I don't want to use the word deal with that, because when you're helping those people, it's hard not to sometimes, like get sucked in, like, oh my goodness, like, this is heavy, or this is, and put yourself in their shoes, and maybe they have other family members that are being affected by what they're going through. So I think the ability to be open about it is not only nice to see and hear, but I think it's necessary. So I kind of like that the whole reason the three of us got together and said, hey, we should probably sit down and schedule some conversations and maybe record them, and because maybe people want to hear what it sounds like on this side of things, right? Exactly. I did remember my earlier question, if you don't mind, and I feel like we're kind of picking on you in your field.
I got you.
It's very interesting, so for what that's worth. But I did want to say, you said complex trauma is, when this trauma is happening sort of repeatedly over a long period of time. Is the sort of time span what makes it complex, or is it that there's multiple types of trauma that makes it complex, or is it both, or either?
Both and,
Both and, okay.
Sometimes it's severity, like something can be really severe, but it hasn't gotten addressed, and so it creates. I swear there's so much overlap between the thing that we do. So for example, imagine something pretty severe happens in your world. I'm just guessing. But no, I have a body, so I know. So then I have an injury, so then I'm compensating in this other way, and it creates other problems. That's what we call, in our field, we call it an adaptation to the trauma. And then that adaptation becomes part of the problem. You know, like one of them could be, you know, people in my world, people who use substances, people who have, you know, an eating disorder, that something occurred, and then out of that you developed a way of compensating for, and then boom, you're creating more problems. And so, yeah, so, but complex PTSD really is kind of held in the land of something developed in childhood that then created more problems over time, and then boom, here you are today.
Have they ever seen any physical manifestation of trauma, like scar tissue or an fMRI,
Yeah.
highly electric area of the brain? And can you speak to
Oh,
any
no,
of that?
I can't speak to it though.
So
There are.
please.
I know. I could go get my book. This is where I can be very like humbly say the neurobiology is there,
Yeah.
and it's really fascinating.
So this actually, I wanted to give you a little break, take the spotlight off of you, and kind of shift it to you, because I feel like this is where I can highlight one of the overlaps, which both of you are already thinking about.
Mm-hmm.
But you used the example of a car accident, right?
Yeah.
So we have that person that's, you know, in your care for that reason, that may simultaneously be in your care because they had a car accident,
Yeah.
and now they have, I don't know, let's say neck or lower back pain, something to that effect. Usually it's one of these things or both. Can you speak to, and I know we kind of touched on this the first time we met, but anything you'd like to sort of expand on, and just for the benefit of anybody that's listening, when there is a physical trauma, let's say from a car accident, anywhere in the spine, let's pick the low back, right? So in the spine and the lumbar region, and you're working with that person, and the physical injury gets healed. I've read that the pain can persist, right? And that's entering the whole sort of realm of chronic pain, and I know that's a broad sort of, we could probably do several episodes on that. Could you speak a little bit to the process that occurs and why we may continue to feel pain even after the injury itself, physical injury, is gone?
Yes, I could lecture for 5 months straight on pain. That is one of my main interests, and why I practice the way I do. I'm going to keep it somewhat low level for our purposes now, but currently we have the biopsychosocial model of pain. I'm sure you guys are familiar with it. Since to give everybody a sense of where we are understanding pain, this is the third model that I have learned since school. I've been practicing for almost 12 years now. So things change quickly, and this is not to say that this is the end-all be-all of pain understanding. Okay. But to answer your question, we may have a tissue-level injury. We are sending those electrical signals up our ascending pathway, up through that peripheral nerve to our spinal cord to brain to typically the sensory cortex, right? Sensory cortex. That generally, see, it's so hard for me not to go super, super deep into it, so reel me back in when I start getting nerdy.
Basic level.
If you are, one of the things we should know about the human body is we are incredibly good at adaptation, right? It's kind of our superpower, in my opinion, as a species. And we are inherently very lazy, right? So what I mean by that is we want to use the least amount of energy as possible to create some sort of outcome, right? So if we're constantly using this energy to depolarize these nerve cells and send that signal up to the brain, that is a lot of work to be had. So eventually, if that tissue pain signal is there for a while, our brains are going to say, okay, well, I can cut out the middleman here and just have this closed loop up at the brain, just saying, oh, my lower right back is hurting. My lower right back is hurting. Even if the tissue level injury is resolved, right? Let's say the nerves calm down or the muscles have repaired, whatever the case may be. We then often have to go back around and undo or unwind or break that closed loop of pain signaling at the brain. There's a lot more to that, But that's what that's what we're referring to with the biopsychosocial model. The biologic being our tissues, our body. The psychosocial is mindset, state, anxiety, depression, anything of the psychologic that we're experiencing. The social is something I've always found really interesting, really and not spoken about as much. We include that because we have a lot of evidence suggesting that. By the way, pet peeve of mine, when we say evidence says, I hate that. Evidence suggests, guys. Suggests. Nobody is 100% confident in anything. Okay.
Except Vahid. Vahid is.
Well, we'll circle back around to that. But the evidence would suggest that there are generally higher pain scores in people with a lower socioeconomic status or lower level of education. So that's where the social side of thing comes from. All of that plays a role into how we experience pain, right? You could be fighting a war, right, and you get shot, but you are highly focused and concerned about your buddy that is also wounded. You got to get him out. You're not going to even recognize that gunshot, right? How is that possible? How can we get a little paper cut and think we are dying and then also be able to ignore some major trauma? I think just reflecting on that is one of the numerous amazing aspects of our body, that we can go from one end of that spectrum to the other dependent on what we need, right? So that's kind of the adaptation, the biopsychosocial model. Hopefully that answered your question, but I love pain. I love talking about pain. I'm sure we'll talk about it more, but it overlaps into every part of our life. Yeah, I'll stop there because I see Vahid's eyes glazing over. No, just kidding.
No, this is so super.
This is good. I mean, we're talking about pain. We're talking about pain, really.
We really
right?
are.
Like it's different, but also overlapping. I'm so happy to be sitting between two people that are so not only like intelligent and know what they're doing, but that you can just see that you enjoy what you do. Like it comes out of both of you really easily. So thanks for making me look like absolute crap sitting here in
you're
between
welcome.
you guys.
You're welcome.
Just like, yeah. No, I love it. I love it. That's actually makes me really excited because I'm seeing so many doors where I'm like, oh, I want to open that door, but there's so many conversations here that I think that I need to reel myself in and just kind of reserve my questions so that we don't end up, taking 6 hours in one conversation.
What about
like-
you? What do you do?
It's irrelevant. Now this
Really?
conversation is amazing as it
Okay,
is.
fair enough. I'll go
I don't know
with
I don't know if I said right off the bat. So I'm a medical doctor, and I'm my core training is in family medicine, primary care. I'm also specialized in obesity medicine and lifestyle medicine, and I'm very interested in lipidology. So I'm pursuing some extra training there. So yeah, my area of interest is chronic disease, mainly because it's what I've been exposed to the most, but also because it's where I feel we suck at treating. We're much better maybe than we used to be, but I feel like we can do a whole lot better when we compare it to, like, let's say, acute disease, right? And what I mean by chronic and acute, I mean, things that have been around for a long time, things like, diabetes, hypertension, high cholesterol, things like that, versus something that might be life-threatening for you in the moment. Maybe you had a heart attack. I think we're much better at handling disease once it's occurred, but we're not really great at how do we drive it back once it exists, or how do we even prevent it from occurring in the first place. All of that fascinates me, and how you and I connected, I want to say maybe 2 years ago, was because I realized I'm dealing so much with behavioral change that I really needed to be able to talk to somebody close to me that I can collaborate with, who understands behavioral change, but who has a background in eating disorders, because that's something that we pick up sometimes, and trauma. So it was kind of like the perfect, I kind of won the lottery that day. I just went on Google, and I'm like, okay, who can I scam? And then, we obviously became fast friends, and then, you and I, this is like our 5th conversation, I want to say, and I already feel like we're going in the same direction. Again, I feel like when our sort of core values align, when our passions in healthcare align, it's easy. So yeah, that's my kind of spiel of what I do. Again, not near as interesting perhaps, but I feel like there is a lot of overlap with what you guys do. Yeah.
Kimmy, no, I do. Don't demolish yourself like that. That I think the connective tissue between all of us is we generally, I think the three of us deal with the complicated chronic conditions of life, and I'm so excited to network with you guys and talk with you guys more, because I just feel like I'm missing so many pieces in my practice, right? I'm very confident on the physical, musculoskeletal, neuromuscular side of things, but the emotional, psychologic side of things, the pharmacologic, physiologic side of things, that's where I need to defer to you guys as the specialists. But it seems like we are all dealing with humans who, this is not something that they just wake up with and they're dealing with it. Maybe it is, right? Especially in the case of a acute trauma. But it's like these slow little insults to their life or their physiology or their anatomy or their psychology. And we are tasked with, okay, we see this patient or client at this time point. We have to peel the layers back from the onion and figure out, okay, what is driving this behavior or this physiology or this pain or whatever it may be. So I'm very curious to hear more about your side of things from the pharmacology, from the physiology, especially with some of the chronic illnesses and diseases that we are seeing more and more of these days, right? The autoimmune, the inflammatory things, the blood glucose, diabetic side of things. I could pick your brain for hours. So how dare you say that you're not as important? You are the leader, my friend. All of your patients will just trickle down to us.
That's exactly right.
How are we doing on time? How's everybody doing on time?
4:50.
Yeah, so we have like, what, 5-10 minutes?
Sure.
Right? We can wrap
Let's
it
do
up. So we could kind of, I guess, tease what I would love to talk about next time. 'Cause you and I have never talked about dietary pattern or diet or what we're eating. You and I have, obviously, not recently, but we've definitely spoken about it.
Yeah.
So as a physical therapist who's obviously in good shape, who's probably on some kind of a workout regimen himself, yes, we're all about complimenting each other here and then watching the videos by ourselves and saying, look,
You look really good.
you're fantastic. Adam, Pegah, you guys are wonderful. I wonder, because I know we haven't talked about this before we started recording, would you be comfortable sharing? So what's your routine? Someone who is a doctor of physical therapy who's an expert at this, like, what does your day look like in terms of exercise, diet, the things that people normally think about when they think about, I need to go get healthy? Are you comfortable with that?
Oh yeah.
All right, here you go.
Oh, we're doing it today.
Now.
I can give you
I
can give you a teaser.
Yeah, a teaser.
Okay. I don't know how to tease this. I am very comfortable talking about all of this. I will say if I break it down into the pillars that you discuss, exercise is the thing I'm best at. I love to work out. That is my mental health. We can talk about my mental health things next episode, so stay tuned. The diet thing, I am very blessed to have the most amazing wife ever who loves to cook, and she is obsessive. Love you, baby, about her counting calories, and that trickles down to me, so it makes my life way easier. But yeah, these things are behavior changes, lifestyle changes, routines. It's just getting used to that, getting comfortable with that, and to me, the most important part is understanding you as a body or as a collection of systems, and what these different titrations of exercise or nutrition do. Right, that's what we have to really figure out. So very excited to talk about it. I will give you guys the secret to my pectorals next time. How about that?
Awesome. Yeah, and then that'll be a cool conversation we can kind of go back and forth on. And any thoughts about that?
Oh.
Would you be willing
Wait,
to?
I don't
You have
know.
your own mic. You're
I was like, give me your
Yeah.
mic. Wait a minute, I have one. There's a lot here on the psychological end, and I think what I'm going to really enjoy about this is that we can't keep ourselves out of the room, right? So the personal becomes the professional in a lot of ways for us. So that's going to be exciting to talk about. Those are the kinds of conversations that you and I have had, even in forming this partnership, friendship that we have, is how do we think about what's health, and because that's really how we then work with our clients. Coming in from a background, many backgrounds that I have, working with people with eating disorders, my own history of confusing messages growing up, in the time period that I did in the United States of what a woman's body should look like, and then having my own injuries that I've had over the years and trying to understand them. All of that comes into the mix of how I take care of my body now, and frankly, having to go against some of the things I learned growing up, and also in a lot of ways coming back to some of the things that I said, okay, well, yeah, my culture did give me this, but it also gave me a lot of other things. So it will be fun to talk about it.
Yeah.
Yeah.
I think that's going to be wonderful. And then also, as we kind of move forward, I'll do my best to sort of break down into like a practical sort of like, okay, what's the takeaway practical? Like, what could we learn from this? How could I apply this? Just for myself and for each other's benefit. I would say before we wrap up, I don't know if you guys watch a lot of TV or not. I love comedy. So John Mulaney does this like live show now on Netflix on Wednesdays. And he always ends his phone calls by saying like, well, what car do you drive, right? So I was thinking like to go completely away from what we're talking about, I'm curious what you guys are listening to these days, music-wise, and then we could wrap with that. How's that? And then since you look the most uncomfortable, here you go.
A certain patient of mine will love this when they see it. I am currently listening to Eurovision 2024.
Are you serious?
I am dead serious. We can pull it up on my Spotify if you want to.
Fun.
Really into the Eurovision songs right now. So,
I'm impressed.
yeah.
I don't know why that made me think of Will Ferrell. I know why, because there's a movie.
Yeah.
All right. I just yesterday for some reason reached back into sort of earlier 30 Seconds to Mars albums. For some reason they just kind of hold a cozy spot for me. So I was listening to one of their first albums. Yeah. Oh, you have your own mic.
Well, it's when you said what are you listening to, I was like, oh yeah, I've got my podcasts and my audiobooks.
That works.
Okay.
Yeah, that and then a song.
Okay, fine.
But I'm curious about the podcast now.
Well.
One podcast, one audiobook, one artist or something.
Okay, so we can definitely take this part out if you want, but
Nope.
I'm actually really impressed by this one podcast called Tangle.
Okay.
Actually, it was a client of mine who referenced it because I was sort of lost and feeling really overwhelmed by like not wanting to listen to anything that feels like highly influencing of my thinking of like what's going on in the world. And so this one, I don't know what the journalist, he created a podcast, which is exactly what I was looking for.
Tangle, it's called.
Tangle, which
Okay.
is like, he talks about, and he's been around for a little while now, he talks about the left, he talks about the right, and then he talks about what his take. And I'm like, thank you, because I don't have to feel overwhelmed by either and feel taken up by either. And so it's been fun to just like sort of listen to him and get a very clean, clear perspective. And he's not afraid to say, that's crazy, or we should stop doing that, but as long as he actually has listenerships on all sides, which is nice. And when people feel like he's sort of skewing in one direction or another, they tend to tend to call him out on it. So that's Tangle. And then the most recent book I listened to, Sarah Manguso wrote a book called Liars. It's very good about like just a marriage. It was I sort of call it. I sort of say things like to my husband. I'll say, that sounds horrifying. It's like a horror story, but very good. And then what I'm listening to when I can listen to music, because usually all day long I'm with clients, but if I'm working or something, I'll just go to Spotify and listen to non-vocals right now. So Krongbin, I don't even know how to say their name, but they're very good. We ended up at the same concert on different sides of the room. And then usually they'll bring up Hermanos Gutierrez is on that sort of list of like ambient background, fun, smooth music. Yeah.
All right. Tangled, Liars, and ambient background music.
Yep.
All right. I think we're all solid. We're all good. Now we can stop pretending to like each other. You guys are horrible at what you do.
Crushed it. And cut.
It's you're still live.
Yeah.